Hello, everyone, and welcome to today's webinar session, Care Partners, Bridging Families, Clinics, and Communities to Advance Late Life Depression Care, Lessons Learned. Before we get started, I would like to go over a few items so that you know how to participate in today's event. When you join today's webinar, you selected to join either by phone call or computer audio. If for any reason you would like to change your selection, you can do so by accessing your audio pane in your control panel. You also have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of the control panel. You may send in your questions at any time. We will collect these and address them during the Q&A session at the end of today's presentation. I would now like to introduce John Feather, CEO of Grantmakers in Aging and moderator for today's webinar. Take it away, John.
Thank you so much, Leo, and thank you all for joining us today. We want to thank our partners, Grantmakers in Health, who are presenting today's webinar with GIA, and to Archstone Foundation for their support of this webinar. According to the National Alliance on Mental Illness, depression affects more than 6.5 of the 35 million Americans aged 65 and older. In 2014, Archstone Foundation launched its Depression and Late Life Initiative, awarding a grant to the University of Washington and the University of California, Davis to support the Care Partners, Bridging Families, Clinics, and Communities to Advance Late Life Depression Care project. We are so glad to have the Care Partners team with us today to share their key lessons learned to date and the next steps to improve depression care in California. In just a moment, I will be turning to Laura Rath, the Senior Program Officer at Archstone Foundation, to introduce our speakers. But first, I would like to turn to Chris Langston, the President and CEO of Archstone Foundation, for his introductory remarks. Chris, thank you for being with us.
Thank you very much, John. And I hope you all will forgive me for taking just a minute. But this is an opportunity I really couldn't pass up, as this brings together 4 of Archstone Foundation's most important grantees and partners: University of Washington and Dr. Unitzer, University of California, Davis and Dr. Ladson, Hinton, Grantmakers in Aging and Grantmakers in Health. This is also, I think, the beginning and an end and a new beginning. Over 10 years ago, when I was with the John A. Hartford Foundation and John was the new CEO of Grantmakers in Aging, I remember I was boarding an airplane and we were trying to talk, despite the announcements and the noise and the confusion, about some new program that would help Grantmakers in Aging revitalize itself, that would capitalize on the exciting work of the members and serve the membership with new ideas and new potential grantees and projects. And so this Conversations with Grantmakers in Aging was born and has lasted these entire 10 years for what I believe is 101 sessions, all of which John has moderated in his inimitable, calm, and thoughtful style. And for those of you who are as committed to the issue of aging philanthropy as we are at Archstone, John has reached out to, through these webinars, 21,000 registrants. And who knows how many people have listened and watched offline through the recordings. I know I have actually done that myself. So if anybody has done anything to proselytize around aging issues in philanthropy, I think John, through this mechanism, has done more than anybody I know. So, of course, John is retiring. This is his last Conversations with Grantmakers in Aging, but I know that his successor, Lindsay Goldman, will be taking over and be looking forward to her taking up this mantle of highlighting the work of the membership, educating the membership, and raising up the issue of aging in philanthropy. So now I'm very, very pleased to turn this over to Laura, who will talk about the actual work of something that's also tremendously important, and I've worked on with Dr. Unitzer for over 20 years, improving depression care for older people. Thank you.
Well, thank you, Chris, for that kind introduction. And I will enthusiastically echo all of your comments about John's pioneering leadership in the field. John, it's a true pleasure to work with you. Now we'll turn to today's topic, Care Partners Bridging Families, Clinics, and Communities to Advance Late Life Depression Care. Specifically today, we have the chance to share with you a partnered approach to depression care that systematically seeks to include community-based organizations and/or family members as part of the depression care team. This is also a follow-up to a webinar hosted by GIA in June of 2019, which is also archived on the Grantmakers and Aging website and provides more of the background and structure behind the work. Today, I have the good fortune to be joined by our partners in this work, Drs. Unitzer and Hinton. When we embarked on this project, we searched the whole country and found the very best in the field. We're so pleased to have them share their insights with you today. Turning to our speakers, Jürgen Unitzer is a psychiatrist, professor, and chair of University of Washington Psychiatry and Behavioral Sciences, and Ladson Hinton is a geriatric psychiatrist, professor, and director of geriatric psychiatry at UC Davis. They are also the co-investigators for the Care Partners Project, and together lead a team of the best and the brightest working to improve depression care for older adults. I always learn something new when listening to them and hope you will too. Next slide, please. Here's a roadmap for the topics we'll be covering today. We'll start with a brief background on the work and the need to improve late life depression care and how the Care Partners work is seeking to do just that. Next, we'll move into findings to date, including preliminary clinical outcomes and lessons we're learning, successes and challenges. We'll also tell you about how the sites have shifted and adapted to the COVID pandemic through the Stay Connected program. And then you'll hear about an exciting opportunity for additional care providers and health systems to join in a learning collaborative planned to launch in 2021, seeking to replicate this model. Next slide. So now I'll provide a brief background about the foundation and our work in this area. Located in Long Beach, California, Archstone Foundation mission is to improve the health and well-being of older Californians and their caregivers. The foundation's interest in supporting behavioral health programs as part of overall health and well-being dates back to the foundation's earliest grant making in the mid-1980s. Then, beginning in 2011, the foundation supported the replication of evidence-based programs that seek to identify and treat depression in older adults in Southern California. Those projects included Collaborative Care for Depression, the program to encourage active and rewarding lives for seniors, also known as PEARLS, and the Healthy Ideas program. This experience in supporting the replication of evidence-based projects to address depression inspired us to see what more could be done to address depression among older adults. And in 2014, we partnered with the University of Washington and UC Davis to test an idea to see if community-based organizations and/or family members could effectively be added to the clinical care depression teams within primary care. And now I'd like to hand it over to my colleague, Dr. Unitzer.
Well, hello, everybody. This is Jürgen Unitzer. I want to thank Laura and Chris for the nice introductions, and I want to thank you all for the opportunity to talk with you today about the work we've been doing with support from the Archstone Foundation to really test this idea of how do we partner clinic-based organizations, healthcare organizations, and community-based organizations to really advance care for older adults with depression. If you go to the next slide, I'll talk just a little bit about why is this important. I think John mentioned there's a large number of older adults who live with pretty severe depression, not just a little depression. And when we're talking about depression here, we're talking about something we call in the business major depression. So when you have that kind of a serious depression, that's a lot more than just having a bad day, having a bad week, or having a bad month. We're talking about a person who really is sort of stuck with a pervasive depressed mood, deep sadness. Often, maybe it doesn't experience it as sadness, but you will find a person like that to just feel like they have no interest, no pleasure from doing things. And along with that comes, lack of energy, being tired, maybe sleeping too much, maybe not sleeping much, being anxious and fidgety and not sleeping much at night, often poor appetite. An older person who's depressed, often you can really see it on them. They're not just sort of emotionally and physically slowed, they're mentally slowed, they're physically slowed. They can have problems with concentration. Oftentimes, depression in an older person will aggravate a lot of the physical symptoms, aches and pains that people have from diseases of aging, such as arthritis. Sometimes an older person who's depressed gets very irritable. Sometimes they have just racked by thoughts of guilt. And when it gets really bad, older adults who are depressed are at serious risk for suicide. That continues to be a serious problem, especially for older men. So when you're spending months or sometimes years in that kind of a state, that's a miserable state that, it's not just a small problem, it's a big problem, because while you're not dead, sometimes you feel like you wish you were dead, and you're really losing some of the most important years at the end of your life. That's the problem we're taking on when we're really trying to deal with, serious depression in late life. Next slide, please. So when we look at what happens to a person who has a serious depression and who's an older person, there's a lot we could say, but I'm going to try to be very brief here. The bottom line is the vast majority of older adults who live with diagnosable severe or major depression will not get any formal mental health care in a typical year. What does happen is a lot of older adults who are depressed will find their way to a primary care provider, could be a family doctor, an internist, a nurse practitioner, somebody who provides general medical care to them. And every year, somewhere between 4 and 5 million older adults will walk out of a doctor's office with a prescription for a medication to treat depression. So primary care providers often now recognize that the person is depressed. They will usually, the typical reaction is, let's write a prescription for a medication. And that's a good thing in that it gets recognized and it can be helpful. But if you follow most older adults who are getting a prescription like this, if you look at them again a year later, only about 1 in 5 will really get significantly better. So this is my only cartoon, I think. I'm not sure if you can read this. It says, of course you feel great. These things are loaded with antidepressants. This is a bit of the nation that we are. We're a nation that likes to take pills, and sometimes a pill can be really helpful, but oftentimes, when you're really seriously depressed, you need more than a pill. So if you go to the next slide, I will introduce you to an approach that we developed, and Chris mentioned this. This is something that goes back almost 20 years. We did some really good work with support from the John A. Hartford Foundation, where we said, can we do better for an older person who goes into a primary care doctor's office with serious depression than just giving them a pill and hoping that it'll work out? So what we developed in partnership at the time with the California Healthcare Foundation and the John A. Hartford Foundation is an approach called collaborative care. What we do there is we take the patient who shows up in primary care and we train their primary care doctor, and we train somebody in the primary care doctor's office to serve in the role of a depression care manager. That could be a nurse, that can be a social worker, it could be a master's level counselor. A number of people can serve in this role. And what they do when the patient comes in addition to the doctor maybe writing for an antidepressant medication, every time the patient is seen, they will administer a brief rating scale to see how serious is this depression. All of the patients will get tracked in a computer registry tool, and if the patient's depression scores are not improving, we have, and this is all the way on the right side of this slide, a psychiatric consultant who meets once a week with the entire team and goes over all the patients in care and makes recommendations for what to do. And the other key ingredient of this intervention is, we need more than that pill. So what we do is we train the care managers in a set of brief evidence-based talk therapies, psychotherapies that you don't have to go to sit on a couch in a psychiatrist's office. You can have that right in your primary care doctor's office. And we use techniques such as problem-solving treatment and behavioral activation and motivational interviewing. And these are 5, 6, sometimes 8 brief sessions that a care manager does with the patient right in the primary care setting, or nowadays actually often by phone, because we're not coming into the doctor's office in the middle of a pandemic. And that can actually work incredibly well. So how well does this work? If you go to the next slide, I'll show you one summary slide from a very large study we did more than a decade ago now, where we tested this approach and he compared it to what happens to people who are in typical usual care. So in 8 healthcare organizations in 5 states, we took almost 2,000 older adults with depression, and in every one of the participating clinic, half of them got what we called usual care. So the doctor would see them, they would often start an antidepressant medication, and we would just follow them for a year to see how well they do. Those are the people on the blue bars on this slide. The other half of the people in the same clinic would get this collaborative care, where a care manager worked with them and provided brief talk therapy, and we tracked their care closely, and we had a psychiatrist who could advise us if people were not improving. And if you look at them a year later, what you see on this slide is the proportion of people who had a really significant improvement in their depression. And you can see on average, although it varies a bit across the organizations, in every single place where we tried this, people who got collaborative care had more than twice as much improvement as people who had the typical usual primary care. So this was a very, very effective intervention for older adults with the depression. If you go to the next slide, about at the same time, we said not everybody wants to come in primary care. Could we offer something that's a bit similar to this in patients' homes? So the PEARLS program shares some of the same characteristics of the clinic-based collaborative care, in that we're identifying older adults with depression, but instead of them coming into the clinic, we have a therapist go out to their home and to do 6 or 8 in-home sessions that often focus on some of the very same concepts. So problem solving, behavioral activation. It's a home visitation program, and because it's in the home, sometimes this program can focus a bit more on some of the social determinants of health, problems like food or transportation or other problems that people have, than what we do in a clinic setting. So those are 2 programs that we tested, we established. They're highly effective, and what we're doing with the project, the Care Partners Project, is to say, how do we improve on that? Next slide, please. What we said is, and this is the idea that we're testing here that Laura mentioned, we said, look, we now know that these 2 approaches work, but not everybody benefits from it. There are still a lot of older adults who are not getting well. What else could we do? So we said, maybe it's more than just having a clinic visit and good things happen to you in a clinic, or somebody comes to your home and good things happen in your home. What if we added someone else to this team? What if we took a community-based organization that can provide complementary services to what we can do in a clinic? Or what if we engaged a person's family member or a friend or somebody who is part of their life and engaged them in the care team? Could we improve access to care? Could we improve the number of patients who get well? Could we maybe address some of the social determinants of health that we're not all that well set up to address in the traditional healthcare setting? That's the idea we're testing. Next slide. So the original model was, we have a primary care provider, a patient, we add a care manager and a psychiatric consultant. That's the collaborative care model. And what we're testing now is, what is the relative benefit of adding another partner, a community-based organization, or a family member and friend? Next slide, please. So the project launched in 2013. We did a good literature review to look at what have people done in this area, and are there some good things out there already that we could build on? And we drew on all of that and started a first phase of the project that ran from 2014 to 2017, where we selected a number of clinic sites and community-based organization partners or family partners to test to make a first run at testing this idea. We learned some things from this phase 1 work, and Ladson will present a bit of the detail on that in just a minute. We launched a second cohort, a second phase of this project that is still in progress, started in 2017. Next slide, please. The sites we partnered with, I'm not going to call them all out by name, but just to say there were clinic and CBO partnerships or clinics that more formally engaged family members in treatment, and they were all over California, Northern California, Bay Area, and then a good number of sites in Southern California. Next slide, please. So that's a good time for me. You got the concept, you got the idea. Ladson is going to now share a little bit with you about what we've learned so far. I'll hand off to Ladson.
Yeah, thank you, Dr. Unitzer, and hello, everyone. It's a real pleasure to be here and share with you both some of the findings to date and also to highlight some of the successes and challenges. Next slide. So as part of this project, we have collected quite a bit of evaluation data, and I thought I'd briefly review that. And if we could click down to the, so we have, as Dr. Unitzer mentioned, as part of collaborative care, CMTS collects data on both process of care and outcomes. Specifically, the PHQ-9 is one of the most important outcomes, which measures depressive symptoms. In addition to that quantitative data, we have done extensive interviews with leadership and staff at all of these different organizations. Next. We have conducted focus groups. So each year we have an annual meeting where we get all the sites together, and we take that as an opportunity to do focus groups on different topics that we think are of importance to the evaluation. Next. We also have collected, as part of this project, a lot of documents. We have the original proposals, the progress reports, and practice coaching notes, and those are important also for the evaluation. Next. And finally, we have collected in both phase 1 and phase 2 some, I think, interesting data on the costs. I have actually published one paper on the costs from phase 1, and so that's something else that we're collecting. Next slide. This is a summary of the phase 1 program participants. So in phase 1, which spanned about 2 years, we enrolled 274 people. As you see that the majority are age 70 and above. The majority are female, and also there's quite a bit of ethnic and racial diversity in the participants in the program. Next. These are the clinical outcomes from phase 1. And so at baseline, participants had a mean PHQ-9 or depressive symptom score of 14, which really indicates sort of a moderate level of depression. 62% showed a 50% improvement on the PHQ-9 after treatment or care within the Care Partners project. 59% achieved a 5-point or greater improvement on the PHQ-9, and the mean change in the PHQ-9 score was about 6 points. And if you recall back to the slide that Dr. Unitzer showed on the impact outcomes, these outcomes actually, I think, compare very favorably to those. Next. So as a result of phase 1, we learned quite a bit, and we learned that there were a number of areas in which some of the sites faced, challenges. And so what we decided to do is to develop what we call tip sheets that map to each of these areas of challenge and highlight strategies that sites can use to actually address those challenges. And so this is sort of a list of the different tip sheets that we developed. We developed these tip sheets actually in an interesting collaborative process with the sites themselves. So at one of the annual meetings, we actually got the sites participants from the different sites into small groups, and they contributed to generating a list of strategies that were helpful to address each of these different areas. Next. So this is an example of one of the tip sheets. This one addresses the important topic of the development of partnerships. And so it really addresses, ways that sites can develop effective partnerships between community-based organizations and primary care clinics to strengthen depression care. And I won't go into the detail, but this tip sheet addresses strategies at both the organizational level and also at the interpersonal level. Next slide. So some of the learnings and lessons learned from the first phase of Care Partners were used to inform the selection of sites for the second phase, or Cohort 2. And so some of the important things that we learned that we incorporated into the requirements for the sites that successfully applied for grants in Cohort 2 were that they really have the impact or Pearl's collaborative care in place before the start of the project, that they articulate a clear communication infrastructure that's needed in order for the two partners to communicate with each other, that there is a clearly identified champion at each organization, at both the CBO and primary care, and also a plan for other leadership to step in if there's turnover. And this is something we learned in phase 1, is sometimes there was turnover of leadership and there wasn't always a clear next champion to step in, and that was sometimes a challenge. And finally, that the sites articulated flexibility in terms of how and when to engage family members or other care partners in care. Next slide. So this is a summary of Program 2 participants. We actually increased enrollment in phase 2 quite a bit, up to 665 total patients enrolled. Again, the majority were age 70 and above. The majority were female, and there was, again, good sort of ethnic and racial diversity in the participants in the program. Next slide. And so this is a summary of the clinical outcomes from phase 2. Again, similar to the phase 1 clinical outcomes, the mean baseline depression score, or PHQ-9 score, was about 15, again, kind of moderate depression. Similar to phase 1, about 64% achieved an improvement of 50% or more in their PHQ-9 score, which is an indication of good depression treatment or improvement. And 73% achieved PHQ-9 improved 5 points or more on the PHQ-9, and the mean change from baseline was an improvement in 7.4 points on the PHQ-9. And these last two indicators, the 5-point plus improvement and the mean change, are actually an improvement over the outcomes in phase 1. Next slide. And finally, one of the really important, I think, findings from Care Partners to date is really the critical importance of social needs and social determinants and their impact on depression in older adults and their importance for treatment. So the unmet needs that we've identified in a lot of these older adults include things like housing insecurity and quality issues, food and economic insecurities, lack of transportation, problems with social isolation, and different, difficult family situations and challenges. And so what we've learned is that these partnerships between CBOs and primary care clinics have really helped to recognize and meet these social needs as a part of depression care. So this slide actually illustrates 3 main approaches to meeting these sort of unmet social needs, which we call patient empowerment, social support, and navigation of resources and services. And so these approaches all fall within the broader theme of establishing connections to self, connections to others, and connections to tools. So in summary, these partnerships between primary care clinics and community-based organizations have allowed for new or different connections that otherwise would not have been possible, at least in a coordinated and cohesive way, leading, we think, to improved depression care for older adults. And I'll turn it back over to Dr. Unitzer.
Well, thank you, Latson, for this really quick tour of what we and a lot of the participating organizations, our clinic and CBO partners have all learned together over the last couple of years. My summary would be there's a lot of value in this idea, in this approach. As often it can be harder to do than to just have the idea. But I think the data suggests that if you do this well, you can make a huge difference for a lot of older adults. If you go to the next slide, I'm going to mention two more things before we go on to some questions. The first one is I will make a few comments on the fact that we're in a pandemic and that we actually had to make some pretty significant changes, especially for our ongoing cohort 2 sites and how we approached it and what we've learned from that so far. And then I'm going to take a look ahead to say, what are we going to do to try to take these lessons and really help other organizations try out some of these ideas. So that's a look ahead and some opportunities that we have with support from the Archstone Foundation. So if you go to the next slide, when the pandemic came, we had some of the very first patients here in Seattle, Washington in February. We had patients very quickly. The sites that we worked with in California had patients, and many of the services that we were providing, that our partners were providing, were either in face-to-face services in clinic or services provided in a patient's home, and all of that came to a screeching halt. So just like all of the health services that we are all providing, we had to sort of take a step back and very, very quickly reinvent things because we were very clear, and we were all sort of clear going in that the older adults that we were serving in this particular program were at incredibly high risk, both in terms of their health, but also in terms of experiencing increasing social isolation. And what we were doing is the social support we were giving them through this program was at tremendous risk. So what we did is we reconceptualized the program a little bit. We developed an approach called Stay Connected, and we said, in addition to serving people who are already quite depressed, we're going to broaden this program to serve some people who our partners feel like are at risk for becoming depressed in the context of this pandemic. And so we included a number of at-risk older adults, and we also lowered the age to be eligible for the program 2 years to 60 and older, because we felt like the partners we work with all felt like we have patients who are at risk, and so we included them. We also included some new components. We developed, I think, a pretty sophisticated but relatively robust and simple engagement and needs assessment that could be done by telephone or some other telehealth technology instead of a clinic visit. We developed a set of protocols that people could use for follow-up phone calls. So rather than having a sort of an open-ended call, we said if this is a structured call that still brings to them some of the work we were doing in person, we might be able to actually make this work on the telephone or via telehealth. We developed some new resources for our teams, and we developed some tools that the patients can use to make this work. If you go on to the next slide, I'll just introduce a few of these things. It's hard to go through all of what we're doing in Stay Connected, but just to summarize, what we said is, what have we learned so far? People need to do things that bring them pleasure. People need to continue to engage in activities that are helpful for them. Those could be pleasant activities, those could be social activities, they can be physical activities, and much of that is now challenged. Many of the things that we're doing before, just to get out of the house, to meet up with people, to socialize, were challenged by the pandemic. So we really sort of said, let's take a step back and think about what are safe activities that people can do. We developed some structured approaches where people could say, these are a couple of good approaches, and then we would work with the patient to say, is this easy to do? Is it hard to do? Is it when would I do it? How would I do it? And we got very concrete working with the clients about how do you do that to try to make sure that people don't get more isolated and really fall through the cracks, and we lose all of the momentum we'd had working with them in a clinic or a home setting. Go to the next slide, please. So again, too much on the slide to really get into the detail, but we developed a couple of tools, both for the clinics that were working and also for the clients. So on the left side, these are some examples, for example, of activities that we would think about with a client: physical activities, social activities, things you can do on your own, spiritual activities. And not every one of these is going to fit every client, but there are things on this list that oftentimes, if you work with a client and you really pursue them well, you can find something that is a fit that really helps a lot. And when we had a plan, we would develop with each of the clients what we call a stay well plan, and that would sort of call out what are the things that they're working on. We would have a group of things we call personal warning signs. So we all have what I would call sort of personal warning signs. It might be my sleep's not good, my eating is not good. There are other things that myself or a partner or a family member could be tracking for and saying this depression is getting worse. If patients are taking medications, we would remind them of what to take, how to take it, and at the bottom of the screen, make it easy for them to reach out by phone or otherwise if they were feeling like they wanted to talk to someone. Next slide, please. So these are actually tools that we found are very helpful. I'm not going to show you data, but we are collecting some data on how people are using these tools and how well it's working for depression. But I would say we're now, have tried this approach with just under 100 patients, and these kinds of tools can actually help modify what used to be kind of a more face-to-face in-person intervention and have it continue to be pretty effective in the midst of this pandemic using a telehealth approach. So that's a good segue to the last couple of comments I'm going to make, which are we actually have learned a lot from this effort, this Care Partners effort to date. And one of the things that's been the most interesting from my perspective is we might have some ideas as academics about what works, what other people have found, what's the evidence base, but we've also learned a lot, and our partners, the clinics we're working with, have learned a lot from doing this work on the ground, and we've created opportunities for them to share with each other. Some of these tools that I showed you, we didn't make up in academics. People took something, we shared with them, and they modified it, and we would then share it with other clinics because it turned out to be a super simple, super helpful, practical tool. And that sort of led us to the next step in this Care Partners effort. If you go to the next slide. So the goal for the last section of this work is to do a larger learning collaborative where we will work with 10 organizations across the state for a year and help them apply some of these lessons that we've all learned and continue to teach each other. So this is an initiative we'll call the California Learning Collaborative. It'll start in July 2021 next year. Hopefully we'll run for a year. We're getting ready to issue an RFP, a call for proposals, that'll go out on January 1. We will do a webinar for sites that have an interest in this to learn a bit more, and then we will solicit applications and review them, select sites, 10 of them, by June of 2021. Each of the participating sites will get $20,000 to help support time and travel for their staff who are participating in the Learning Collaborative. And we'll kick it off with a call in July 2021, and then we will either have, depending on how we are doing in terms of how safe it is to travel and so on, we will either have some in-person or some virtual meetings, and then a bunch of learning work in between. If you go to the next slide, I'll unpack that just a little bit more. So we will, in the next summer, start with some informational webinar, some opportunities for people to get to know each other. And then on October, we will have a first day-long in-person meeting where we're going to sit down with participating sites and a bunch of experienced faculty and really get into how do you do this work, how do you strengthen your existing partnerships, how do you apply the tools that you're using. And we're going to do some QI work using sort of pretty standard PDSA approaches with each of the sites to try to focus on some key areas that they want to make improvement in, and in between the in-person meetings, we'll have some action periods where people are at their site working on improving in a particular area with some feedback. We'll create opportunities for the sites to share using a discussion board, using a learning management system where everybody can share their progress, and some calls, in some regular calls in between, and then we'll have a second in-person meeting at the end of the Learning Collaborative. That's the game plan. The one part we don't know yet is how much of this is going to be possible to be in person. I hope all of it, but we'll have to see. But if not, we can certainly do this, very successfully also, or do components of it as virtual. Next slide, please. So who should participate in this? And this is where you all can help us, and I would really appreciate it if you all can help us get the word out about this opportunity. We'd like to work with clinics in California, primary care clinics that have a community partner identified that say we want to work together to help improve depression care for people who are 60 years or older. So there should be clinics that have, a good sample, a good number of older adults. It could be, for example, a clinic that treats a lot of Medicare Advantage patients, or a safety net clinics that serves older adults. They can be urban, suburban, or rural. And we would also be very happy to have applications from community-based organizations that say we found a strong clinic partner to do this kind of partnered work. If you'd like to learn a bit more about this opportunity, we have a web link here where you can learn, or you can pass on to somebody who's an interest to learn a little bit more about it. And if you go to our next slide, we'll take a few questions in a minute. Let's go to the next two slides. I think you have access to these slides. Go to the next one. We also have, we did a very brief tour of this. We have a number of publications from this project that we'd be happy to share with you. And if you go to the next slide, we also have a number of resources where you or others could learn a bit more about the concept of collaborative care, about the PEARLS model. We have a Care Partners website that has all these publications on it. And then a number of other resources that we be happy to share with you if you find this is an interesting area, or you'd like to engage with somebody around doing this kind of work. So that was a very quick tour. We want to have some time for questions. I really appreciate you all being here with us today. We are super passionate about this work, and I think we have learned a lot, and I think there's a lot of good that we can all do for our older adults who are living with this problem. Thank you.
Well, thank you so much, Dr. Unitzer and Dr. Hinton, and to Chris and to Laura from Archstone Foundation as well for these wonderful presentations and the commitment to this work over many, many years now, which is really so outstanding. We do have some time for questions, and if you have questions you'd like to ask our panelists, please go ahead and write them into the box under the question part in your panel that you have on your screen, and I'll be asking them of our panelists as we have time. So the first question, and there's a couple of these, is how is this program being paid for? Obviously, there's philanthropic support, but how is the program paid for in general, both PEARLS and the other programs that you talked about? I'll let either of you answer.
Yeah, I'm going to start on it, and I'll see if Latson can add to that. There are components of the program where the answer is really straightforward. So for example, collaborative care, when we started this work, making the case that it works, this was a real challenge. It was almost all paid for by foundation grants or other kinds of grant support. That has changed tremendously. So about a decade ago, based on a really strong evidence base for this, we started work with CMS and with state Medicaid programs and with commercial payers that created a number of billing codes that allow primary care clinics to bill for comprehensive collaborative care services. So there's a new set of billing codes that all primary care clinics can bill to Medicare that allow you to charge not only for the primary care provider seeing the patient, but for the care management activities, for the psychiatric consultant time. And if you go to some of the resources on the AIMS website, we actually have a fair amount of information about those codes, how you use them, how you build them. That's probably the most important thing for people to know. This is something for which there are formal billing codes. The partnered activities in the community, sometimes what you can do is you can provide some of the services that normally might happen in a clinic that you can bill a collaborative care court for, and you provide them, and your community partner provides them. And so what you have to do is you have to find a way to share the resources that come from billing the collaborative care codes with your community partner so that the work gets done by a team. There are probably some other approaches. It varies a little bit, but that's probably the core thing for people to know. There is a way to get paid for by most insurance companies now for doing good collaborative care. Latson, I don't know if you want to add anything.
No, I think that's a great answer. I don't have anything to add.
All right, we'll move forward then. You have mentioned telemedicine and so forth a couple times, and of course, one of the outcomes of COVID is not only the greatly expanded use of telemedicine in a variety of settings, but particularly, I think, in the mental and behavioral health arena. But of course, all of those things are waiver programs at the moment, so they're not necessarily going to continue to be paid for unless those waivers are extended. What are you seeing in terms of the ways in which that is a opportunity that will remain once COVID is over? Dr. Hinton, you want to take that one?
I think I'll defer to Dr. Unitzer on this one.
Yeah, so I think we have all learned a ton about what's possible to do, with telehealth care. We actually knew 15, 20 years ago when we were doing the impact study where we were testing the concept of collaborative care that while it was really good and helpful to make your initial connection with an older person who is in treatment for depression in a clinic or in a home visit, sometimes it's very hard for older adults to make it into a visit. And once you know somebody really well, doing another session of problem-solving treatment or behavioral activation or working with them on their depression, it's a heck of a lot more convenient if you could just do that by a phone call. So back then, that program was grant funded and we didn't have to bill insurance. And so we had some of our care managers do a lot of this work on the phone, and it worked incredibly well. So when we worked with CMS to build the billing codes for collaborative care, we made it clear that that didn't have to be work that was done in clinic. It could be work that's done by telephone, and the billing codes allow that work to be done by telephone. That's even pre-COVID. So for this work, there is opportunity to use the telephone. When the pandemic came, it went almost all of it went to telephone. And you're right. More broadly, there is some question about will insurers, the federal insurers, will the Medicaid plans, will our commercial insurers continue to pay for telehealth visits, and will they pay for it at parity? And I would say that we don't know the answer to that yet. We have clearly established with this project that a lot of good and very effective work can be done by telephone. And so hopefully we can use that data to make a strong argument for that. But like I said, for this particular type of work, we were already in pretty good shape, billing, the collaborative care codes for telephone services even before COVID.
Yeah, I'll just add that.
Go ahead.
I just wanted to add that to emphasize the point that I think there are lots of really wonderful opportunities to strengthen depression care and care for other kinds of conditions through technology, and which includes telemedicine, telehealth, things like online resources, text messaging, etc. So I think it's really a rich area for further work.
One more comment on this. One of the biggest concerns I would have around this is creating further inequities. There are people who don't have access. So some of the insurers will say it has to be a televideo connection where you can see the patient. And that's, of course, nice when you can make that work. But there are people for whom that's going to be very hard. They don't have good video. They don't have the right kinds of phones. They don't have the right kind of internet. And while a telephone call may not be quite as good as a televideo session, the person who can't afford to do a televideo session may need our help more than the person who can. So I feel very strongly that we make a case, all of us make a case that for a person for whom telephone is the only option, while it may not be quite the same in terms of quality, it's very, very important that they have access, because otherwise it becomes, they have access to nothing. They're already a disenfranchised group.
Yeah, that is very important. We've been involved with trying to develop our resources in rural areas of America, and that is the pervasive issue, is access to this kind of technology and bandwidth and so forth. I have a philosophical question for you, and then we'll move to our final comments after that. But you've been involved in this work for a long time, and this has been a focus of the aging community for a long time. Do you think that we're making major progress on late life depression?
Well, I'll start, and I'll let Latson, give his thoughts. I do think that there has been a lot of progress. There have been a couple of stages of progress. The first, when I started in this field, almost 30 years ago, people really were getting no attention. If they had depression, they would come to their doctor's office. People just ignored it, and they might be suffering terribly. And the first big progress had nothing to do with the work we did. It was the fact that antidepressant medications came along that were easy to use, and all of a sudden doctors said, hey, this is something I could do something about. Now that was a good first step, but not terribly sufficient. We have learned that there's a lot more you can do. And I think there's a lot more older adults who are now actually getting offered things more than a pill. I think that family members have gotten much better at sort of looking at their older parents, their older family members, and saying, hey, is this part of normal aging, or is this person depressed? Is this something we could do something about? And I think the more we all can go out and say, this is something you don't have to live with, you can get better. The more we see people being empowered, or family members being empowered, asking their doctors, is this good enough? Does this person really have to be so depressed? And I think actually we've seen quite a bit of progress in this area.
Yeah, I agree with that. And I would point to care partners to highlight, two areas of kind of innovation that I think have promise for improving depression care. One is one that we've touched on already in this webinar, which is addressing the social determinants of health and social needs of older adults who have depression. And I think there's a lot of potential there, and I think that's an advance. I think the other thing that we've learned in this project is that engaging family members and making them part of the team is not always easy. But it may be a really important strategy for certain older adults who are depressed. So I think those are kind of two exciting areas, I think, that have been really advanced through this project.
Thank you so much. Unfortunately, we're coming to the end of our time together, but I do want to ask each of our speakers to give us your last words of wisdom on this. So, Dr. Unitzer, we'll start with you.
Yeah, I would say, just repeating really what I said earlier, this is an area that has an enormous amount of potential. We are still, in a society where many of us are going to have, if our medical health holds up, a good number of years to live after retirement. And, being depressed during that time just robs you of all of that, life that you have left. And what we have here is an approach for a problem that's not incurable. Well over 70% of the people that we're helping in these programs are getting better. And it makes a huge difference to spend a couple more years to be seriously depressed, or to sort of not be depressed and be able to make the best of the time you have. So this is a high potential area. Anybody who's not in this area, take a good look at it. Encourage people to look for good care. If you're not improving, if the care you're getting is not getting the job done, that's not good enough. ask for change. When you change things, sometimes things do get better. Actually, most of the time they get better. Thank you.
Thanks. Dr. Hinton?
Yeah, just two thoughts. The first is that, good depression care is certainly more than what is very narrowly defined as sort of medical care, in other words, medications. That, through collaborative care, for example, as Dr. Unitzer described, one of the real important things that model does is it improves access to non-pharmacologic, evidence-based types of therapy to treat depression. And through this project, I think one of the really important things is that we've really expanded to even a more holistic view of the person and their social context, to really, through this partnership with CBOs, to expand our view of sort of depression and depression care to incorporate the addressing of social needs and social determinants. So that would be one thought. The other thought is that I think this work has relevance and importance not only for late life depression, but the other area that I work in quite a bit is around dementia care, and specifically, family caregiving, improving the quality of life for older adults living with dementia in the community. And I do think that the kinds of partnerships and the issues that we've been sort of addressing through this project have real relevance also for improving care for people with dementia in the community, and also supporting their family caregivers. So I'll stop there.
Well, thank you so much. Dr. Laura Rath.
Well, thank you, Dr. John Feather. And I'd like to close by extending a few words of gratitude. First and foremost, a special thanks to all of the healthcare workers, who are running a marathon of care in the face of COVID, including our speakers today. Thank you for taking your time away from your patients and clinical services to share these important insights with us. I'd also like to thank our partners in this webinar, Grantmakers in Aging, Grantmakers in Health, the University of Washington, and University of California, Davis, and the entire team at those organizations. And finally, thank you to everyone who tuned in today, the clinicians, researchers, funders, and supporters who are all working together to improve depression care for older adults in the face of a persistent pandemic of structural racism and the global health pandemic that we're facing. This attention to improving care is needed now more than ever, and hopefully together we will be able to reimagine care, whether it's through telehealth or other ways that will help us better address depression care for older adults and address inequities in healthcare. Thank you.
Well, thank you. Dr. Langston, any final comments from you?
Well, thank you, John, and thanks to everyone, as has been mentioned. If anybody listening wants to learn more about the work of these grantees and the many other grantees of the members of Grantmakers in Aging, I highly recommend that you think about next fall's virtual meeting. The annual meeting is sponsored by us in Long Beach, but it will be in the convenience of your own home. So think about that. We'll be getting the benefit of telecare in lots of different ways. And despite the fact that it might seem like it's easy, if you had watched the behind the scenes work here for this webinar, you would know that it takes an army to produce these kinds of things in a way that doesn't glitch and doesn't have problems. So we are a lead sponsor of the 2021 Grantmakers in Aging annual meeting, but we hope that others will join us and help meet the burden to produce this kind of excellent content for everyone. Thank you.
Well, thanks. And thank you to all the speakers today. We will, as we always do, make this presentation available to anyone who wishes to view it later. And we do encourage you to share that with anyone you want. Anyone can access the program for free later on. You'll be receiving an email in the next few days. I do want to take this one moment to say thank you to everyone. As Chris said, this will be my last time to moderate these sessions. It's been a fantastic experience. I've learned so much from both our experts, but also from the questions and participation of the audience. Lindsay Goldman will be taking over the role in just a month or so, and I know you'll find her to be a very engaging and perceptive leader. I also want to particularly thank Emily Brancy from our GIA staff and Alice Daniels as well, who work really hard to make these webinars appear so seamless and professional. It is not easy to make these things work, especially when you've done 101 of them. And so it really is a complicated business, and we appreciate that. And we also appreciate all the collaborating organizations. I do want to send a shout out to the John A. Hartford Foundation, who has sponsored this webinar series from the very beginning, when actually Chris Langston was still with the Hartford Foundation. So I personally, even though I'm retiring, I will be remaining in the field of philanthropy and aging. So I know that our paths will cross again. Until then, I wish you and your loved ones a wonderful and peaceful holiday season. Please stay safe until we meet again.